Hello, Dorota Religa is my name. I am professor from Karolinska Institutet, Stockholm, Sweden, and senior consultant. My research focus on patients with Alzheimer disease, other type of dementias, and multimorbidity and frailty. I am here to discuss with Robert the findings from the major conferences, and I am here on CONy, Controversies in Neurology in London, together with Robert.
And my name is Roy Panetsky. I'm a practicing general adult and old-age psychiatrist. I'm based in Munich. I'm head of the old-age psychiatry department at the University Hospital. I've been doing Alzheimer's disease, clinical Alzheimer's disease research for over 2 decades now. And I'm here with Dorota today. And we will cover the most exciting findings that were presented at 2 conferences this year at ADPD in Lisbon and at the CONy conference in London. And we will have a very specific focus on the new disease-modifying therapies that are already available in some countries globally and will possibly become available in the UK and Europe as well. And in relation to that, we will also focus on biomarkers, on blood-based biomarkers in particular. So, Dorota, can I maybe ask a question to just kick off our discussion? What are the main reasons that an earlier diagnosis is becoming more and more important when we talk about Alzheimer's disease?
It's still early diagnosis is rather a research-based concept, of course, for studying both biomarkers and new therapeutics. It's important with early diagnosis. However, in the clinics, we usually set about timely diagnosis. I work a lot with Swedish dementia registry, so mean age of our patients with dementia, there is 79. It's a little bit different age when you have a research diagnosis with biomarkers and clinical studies, because then people are usually a little bit younger. In therapeutic study around 72, and of course has less comorbidities. So timely diagnosis is important, and also in clinical reality you usually need to, after 1 year, 2 years, if you have cognitive impairment diagnosis, my cognitive impairment F067, according to ICD-10, you need to repeat the diagnostic workup again. So maybe 1 year, 2 years, so it's a dynamic setting. But of course, biomarkers, you can maybe add something more on that, are important to make it more accurate and more, little bit earlier, of course.
I agree, and I also like the term timely better than early. Early sounds like we are trying to do population-based screening for amyloid positivity, for example, using biomarkers in seniors without any cognitive complaints, which I think doesn't make too much sense clinically, and it's also dangerous because we don't really know what being amyloid positive without having symptoms actually means. So the term early diagnosis is a bit misleading, I think, and what I think we need to do is a case-finding exercise. So we want to identify in seniors, older individuals with minor cognitive complaints, early Alzheimer's disease cases, and that's what early diagnosis should mean, I think. And timely probably captures this concept a little bit better.
Yeah, because for screening, I agree with you, it's absolutely no time for clinical setting for screening of big population. Dementia is very common disorder. Alzheimer disease is common disorder, but regardless, it's no time, maybe in the future, because we got a question about the future, but it's not in near future to start with screening. You need to be really, the study needed to be much more broader and involve larger population with diversity, inclusiveness, and really be able to give us an answer for that.
And I think the field is undergoing this kind of paradigm shift where we're moving from this combination of a clinical syndrome, dementia with the pathology, the underlying pathology, and only if you're in the dementia stage of Alzheimer's disease, you can actually diagnose the disease. And we're moving towards a much more biologically focused concept of the disease, of course, which is based on biomarker findings, and which sometimes leads to this situation where the disease can be diagnosed in research settings, at least, as you mentioned, without only individuals who don't have any symptoms. And we're not quite there yet. And I agree that that's probably something that will happen in the future, and where the field is slowly moving, but we're not quite there yet. And maybe it's also irrelevant for the upcoming treatments, if we can talk about that a little bit, because they're not intended to be used in individuals, at least currently, who don't have any symptoms. So early stage Alzheimer's disease means individuals who already have minor symptoms. And I think that's what we need to focus on right now. And I'm just curious, in Sweden, so what kind of biomarkers do you typically use? Is it CSF or PET or blood-based biomarkers already?
In a clinical setting, it depends if it's memory clinics or primary care setting. In primary care setting, we don't use so many biomarkers for today, but in specialist clinics, of course. So we use cerebrospinal fluid, A-beta 42 to 40, and tau, phospho-tau. This is established and very relevant biomarkers. We started in little bit research-based, use some blood-based biomarkers, but of course they are not clinically.
And they're not approved
They are not, and this is also another question: when you can say you start to use a method in the clinical setting, because in a lot of memory clinic is like between most of the patients already contribute in the research. They are already involved in the research in our memory clinics. So it's both research and clinic in the same time. And blood-based biomarkers, most hot from this congress is, of course, phospho-tau. Earlier it was 181, 217 phosphorylation, but as we've seen, now we can have tests for multiple point of phosphorylation, that you can have one test for different phosphorylation. It's a lot of discussion which phosphorylation site is better, worse, but of course blood-based biomarkers are probably a new things that will come to the clinic. I don't know if you think it will be near future. What do you think? It's a time to start to use them? And
I personally think that it's a little bit too early. So as far as I know, a few of those blood-based biomarkers in the US, in most US states, they're CLIA approved, so they can be used. They're not FDA approved, I believe. But in Europe, I think there is no blood-based biomarker approved, not in a single country, I believe. And most of the evidence that we have is from retrospective studies, where you define your cutoffs in one study and you apply the same cutoff in the same study. So it's always a bit biased. You have results from memory clinic populations where the kind of a priori the prevalence of Alzheimer's disease is very different and much higher than in the general population, which biases the results. And there's obviously findings on different factors which influence the biomarker levels, such as body mass index, because of the higher blood volume in people who are obese. You have lower biomarker measurements. Or we discussed that yesterday. Kidney function is important because of the clearance of the biomarkers. And I don't think we don't have enough evidence to kind of use blood-based biomarkers, no matter how good they are in those retrospective cohorts in our memory clinics. But I don't know, what do you think?
Yeah, some small data set were presented, for example, even from Sweden, from Oskar Hansson and from primary care, a little bit setting, but this is quite selected population anyway. And again, if we take back to real life and age 79, you have already different kidney function, as you mentioned. And this prestanda of biomarkers should be checked much more detailed. From the other hand, it's not one point that today we start to use biomarker. We need to develop this together always, maybe having this information to the larger registry that we can see how in real life these biomarkers perform. And of course, it's also a question about health economics, because even blood-based biomarkers are a little bit easier to have. And then we can extrapolate the data. Maybe phospho-tau can give you some information. So otherwise, you need to take from PET, because PET is kind of already used in the clinic, even it's a very expensive tool, but already used in some small subpopulation of patients. So, but again, the cost of this, and then probably you need to repeat it several times. It will be not one measurement, but you will need to again, and it will be a question how often some patients would like to be followed up. Is it clinically we follow up patients with usually once a year. It's a clinical reality. When they want to,
if at all,
if they want to have a new assessment, I don't know. We don't let them be followed a little bit earlier if they want to have a new memory workup. But this is we will see. At least we can contribute to more data, because these tests are, as I said, our memory clinic settings contribute to the research a lot. So it's going hand to hand, but absolutely it's too early to use it broadly in the clinic. However, you can have a situation that patient himself, herself will order the test.
Sure, yes.
So what will you do? Will you?
But that's, people are using Dr. Google for all kinds of different things, and that's kind of a problematic situation. And if they have access to genetic markers or other blood-based markers, that makes it even more complicated. What I also wanted to add is, so I agree that probably the next step for using blood-based markers would be in memory clinic settings where you have this a little bit biased population, but we already know that the performance of those blood-based biomarkers in this population is pretty good, probably as good as CSF or amyloid PET. So I guess that will be the next step, to actually start using them as a pre-screening tool, or to rule out Alzheimer's disease, for example, and then only do PET scans on certain individuals. Probably not in primary care, we're not there yet. And I think we need also research in ethnically more diverse populations, which are usually not included in studies. And I believe there are results showing that ethnicity per se doesn't really have a big effect on blood-based biomarker concentrations. But risk factors do, and risk factor profiles in different ethnic populations are different from kind of the typical study population that we have in Europe and the US. So I also work in Sheffield, and what we're trying to do there is, because Sheffield has an ethnically very diverse kind of community, and to do a blood-based biomarker real-world study there to see if the different risk profiles and how they influence the blood-based biomarker measurements. We don't have those results, I don't think, which makes it a bit challenging. Do you use, by the way, PET, amyloid or tau PET, routinely in your memory clinic? Is that
No, not routinely, but we perform in some patients amyloid PET, not tau PET. It's more research based, and then we don't have it in Stockholm. We have it more in Uppsala. But this is possible to use amyloid PET if you need it. So for some problematic cases, and especially in patients that you cannot perform cerebrospinal fluid measurements. For example, if patient does not want to stop anticoagulants or something like that, this can be situation that it's more often now that people have treatment with anticoagulants, and then you have in different setting, of course, different how you perform lumbar puncture, if it's needed or less needed, but amyloid PET we can perform clinically.
And do you think that, so let's assume that lecanemab or donanemab will be approved later this year in the European Union. Do you think that there will be a requirement for amyloid PET to decide who's eligible for the treatments? Or do you expect that CSF measurements will be equally fine?
We discussed this several times. From our point of view, a lot of studies are based on PET, amyloid PET. However, in countries when you have cerebrospinal fluid, easily done. In memory clinics in Sweden, we use in 90% of patients, they have cerebrospinal fluid.
You do a lot of lumbar punctures
yeah.
in Sweden.
Yeah, not in the whole population. Swedish Dementia Registry with primary care, you have 50% of the population with cerebrospinal fluid.
In primary care?
Like together.
Well, okay,
yeah.
but that's...
but for memory clinic, you have 90%, and of course, PET is less common in memory clinic, because if you have cerebrospinal fluid, it's very rarely that you need to have as well PET. We'll see. It will be a lot of regulatory basis as well. What will be required? That we already built in Swedish Dementia Registry drug module. So if some therapy is approved, we can follow. So we put the variable there, amyloid positive, if you are amyloid positive. And of course, it's a discussion, even in PET, what you mean. You have the centiloids, you have different measurements. In real life, it will be also an issue how well this will be evaluated, because in research setting is always easier. So we discussed that probably we can use both, or PET or cerebrospinal fluid. What do you think?
Well, I think the situation in the US, for example, is you can use CSF or PET as your amyloid measure, and I would expect the same to happen in Europe, I guess. Because if it's only PET, there is not enough capacity in most countries to do a PET scan. And CSF sampling is relatively easy, but it's also a culture, I think. So just based on my experience working in the UK, in the NHS, as a psychiatrist in particular, it was extremely challenging to do lumbar punctures because it's just a very different culture. In Sweden, it seems to be extremely easy to do lumbar punctures because it's kind of an accepted measure. Germany is okay, I think. We do a lot of lumbar punctures, even in psychiatry. But there are kind of culture differences between countries, and convincing doctors and patients that lumbar puncture is something that it's really safe. It's nothing spectacular. It's required. It's much cheaper and more accessible than PET. That will probably require some educational activities to convince people. But I would expect CSF and PET to be equally used to decide who's eligible for the treatments.
In the research, when you ask patient what was the less comfortable test that you done during memory testing, it's not cerebrospinal fluid lumbar puncture, it's neuropsychological test.
Absolutely.
So patients, when they did once neuropsychological test, they already know. So it's also...
I mean, that's another important topic. We almost always just talk about biomarkers, and we never really talk about cognitive tests or neuropsychological assessments. And there's definitely a need to improve the existing tests also for the phase 3 trials, because just using the clinical dementia rating, some of the boxes, is obviously not ideal. It's not sensitive enough. It's kind of a complicated concept altogether. It's accepted by FDA in the US. I'm not so sure about EMA. I'm not sure if they like it. What do you think about digital biomarkers? So do you think that that's kind of, that there's a development which could change the field and make neuropsychological assessments a bit more kind of less invasive or less stressful for patients and more sensitive for early changes?
Yeah, this is surely some future. It's again a question how long from the clinic, but we have already like digitalization of the normal, like very common clinical test like MOCA, and even Minimental you can put on your iPad, and of course you can have some other test. NEET is really Minimental test states examination that we use quite common in Sweden. Is so old as me. So of course you need to have different, better. People wanted to have quicker test, but still you need to compare this prestanda of this test and norms. You need to have norms for the society. Society today is of course different, so you need to have what is the normal prestanda, what is the not normal. Like even clock test today, we discussed this very many times, it's relevant or less relevant. Of course, it's too easy test. You need, and all these tests should be quite less time consuming. So if you have digitalization and you can get passive information of the patients, well, both active, passive, question will be how many behavioral changes you can also detect, function. You can have also not only cognition testing, but function in digital way. This is future. And this is together with the drug, as you said, because if the drug is approved in Europe or UK or other countries, you need to have scale up some screening, memory workup, and again follow up.
And you're not going to achieve that by doing MMSEs, I guess. Let's maybe talk about the two drugs that will maybe potentially, hopefully become available later this year, lecanemab and donanemab in Europe. Do you remember any new insights from ADPD or CONy that would be worth highlighting here?
Yeah, this was a discussion if the drugs will be available or helpful to the most of the patient with Alzheimer, because this is the congresses are observed also by patients and families, and they have a hope when the drug are registered that my relatives or myself will be able to be treated with the drug. And of course, we have to highlight that the drug will be helpful for some of the patients, but not for majority of the patients. So this is a point of the discussion. So the patients in the clinical trials were younger, have less comorbidities. They had different body mass index with some range, and no patients over 90 years old were included. So this is a lot of exclusion criteria.
And do you think these criteria that are emerging from the, I believe, the phase 3 studies, because that's the over 18 months, so it's quite a limited data set that we have, and the population in a real world setting that will actually be treated will probably be much broader, different age ranges, different comorbidities, risk factors. Do you think it's realistic to apply the inclusion-exclusion criteria from the phase 3 trials to our actual patients in the memory clinic?
I think we should do that, at least in the beginning, because we have no data to do this in the other way. So we should try, and especially exclusion criteria, to think about this risk-benefit ratio for the drug. Very good example, when we come back, it was highlighted, it was anticoagulant therapy, because it's also dynamic status. If patients are not on anticoagulants, but maybe they will need it, or they will get stroke, what to do? We will need to have this in our mind. That is a quite large population with anticoagulant. They are really highlighted as contraindication today. But again, it's not like the same ApoE status or some abnormalities in the brain imaging screening is different, but anticoagulants, it can change the status.
One important topic at ADPD was ARIA, amyloid-related imaging abnormalities, as the most important adverse event with all of these anti-amyloid antibody drugs. And obviously in carriers of the epsilon 4 ApoE allele, the frequency of ARIA is higher. And if you are a homozygous carrier of two ApoE epsilon 4 alleles, your ARIA risk is quite significantly improved, and that's going to be difficult to manage. And I think there's a question around, will it be mandatory to do ApoE genotyping in everybody before they receive any treatment with lecanemab or donanemab? Or will it be up to the clinician to decide if that's required based on family history? What's the implication for the patient's family if they know that the patient is a ApoE epsilon 4 carrier? Do we completely exclude individuals who are homozygous carriers from treatment? So these are difficult questions, I think. And I think initially I would personally exclude homozygous carriers from any treatment, because the risk-benefit profile is not ideal in those situations. I don't know, what do you think? How would you manage that?
US are quite clear about that. And first the question is, if you take ApoE routinely, in US you can also use the drug without lecanemab, even you don't know the ApoE4 status. It's allowed, but of course it will be very rare, because you should be able to explain the patients importance of that, and then of course following the side effects in more different way. But my question is, do you take ApoE4 routinely?
No, not at all. Not at all. It doesn't have any diagnostic value. It doesn't have any meaningful prognostic value. I think in the memory clinic, it's not useful at all for research, of course. But I think for the new anti-amyloid treatments, that's a different situation. I think it is helpful for risk prediction, but it's a very difficult conversation that you need to have with patients, I think.
Yeah, and then the discussion with patient about probability and risk increase on the individual levels, we will need to be prepared for that, of course. But it will happen if needed. But you need to find the right patients that the risk are not so high as you mentioned, and the benefit is higher for using.
And because you mentioned benefit, I remember another important discussion at ADPD about meaningful benefits. So how do we define if a drug has a meaningful benefit or not? And we asked the audience during the session what they thought would be the best measure of meaningful benefit, and then quality of life came up as the kind of the top hit. And quality of life is a bit of a tricky concept. It's difficult to measure. But I think it's clear that just kind of a change on the CDR-SB, for example, is not an ideal indicator of a positive treatment effect. That's probably also so if the drugs are approved in these, I mean, people will ask, I mean, what are the risks, what are the benefits? And I think we need to engage in kind of a discussion with the patient, try to find out what their expectations are, try to tell them what their realistic expectations are. And I'm not sure what the best kind of explanation is. It's not very helpful to tell them, look, the drug results in a 30% decrease of decline or delay of symptom progression. No one will understand that. So what do you think? So in these conversations, have you heard anything at the conferences which might be useful to have these conversations?
Yes, we have a good possibility to discuss with US colleagues. They already treat patients, most of them, they highlight some clinical judgment, regardless all scales. Even many of the scales you don't use in routinely. Of course, in university setting, you can put on a lot of scales that you can measure. Quality of life, as you said, is very difficult because with progression of the Alzheimer's disease and dementia, maybe individuals thinks they are more healthy, so themselves, so quality of life can be even higher, measured higher, because the inside is little bit lower. But many of our US colleagues during the CONy, they said about that the clinical judgment is one of the most powerful still possibility to judge the effect, and of course this risk benefit. And coming to that, it was also a nice conversation. How long should we keep going with the treatment with the amyloid target therapy? And most of the studies are around 1.5 years. And should the treatment be stopped after 1.5 years, or should we continue? Should we stop over one night? So also US colleagues, the most important is maybe to see in PET the effect of the drug. You can have maybe by phospho-tau again to biomarkers, but most of them, in the studies, you could see if the PET, you could see decrease of amyloid in the brain, around 20 centillions, and then you probably should stop. So maybe not time directly is the most important to continue. What do you think?
Which I guess in terms of the costs is very important. So you can't just continue giving a drug which will be quite expensive. And this is an amyloid targeting drug. So as soon as amyloid is removed from the brain, you can probably stop, and then it slowly starts accumulating again. But it will take some time for amyloid to accumulate to cross a threshold where it is harmful again. So absolutely, it's just kind of in terms of the European healthcare systems, it will be tricky to do 2 PET scans, one before and one after, and blood-based biomarkers will hopefully be a good solution for that. Absolutely. I mean, and what do we think about management of ARIA? I mean, I guess there will be a requirement to do follow-up MRI scans, 4 to 5, during the first 12 to 18 months, I think. That's probably an important safety measure. And I also remember an important topic from ADPD about the longer-term treatment effects, because as you said, we only have from the phase 3 trials the 18-month data, and then there's open label data available, I think, and it was presented at ADPD up to 25 months maybe, and it looks like the difference between placebo and treatment groups is increasing because of the delay of symptom progression. So the benefit will hopefully increase over time, but we don't really know. So that we need more data to prove that, I think.
Yeah, everybody who start the treatments will need to have pre-booked MRI. It's needed by regulatory body. We'll see how often, if we follow all the schedule. Risk for ARIA is most in the beginning of the treatment, so it's reasonable to follow that. But this will be another issue when ARIA will come suddenly, maybe during the weekend, some symptomatic ARIA. So then we need to maybe educate also other professions how to, what happen, because this is not a clinical trial population. The people will be not having the direct number to someone.
And also train the radiologists, because most of them are not familiar with ARIA.
So pre-screen, pre-booked MRI is maybe easier to handle, but this kind of not so often, but still maybe symptomatic ARIA. will be more difficult, and we need to prepare both radiologists, but maybe even some emergency medicine or some other possibilities too. And of course, report. I think our chance, a lot of discussion in the congresses were that everybody could contribute to real life data with kind of common registry, like we try to build even together.
I mean, that's maybe, so if you want to close this discussion, that's maybe kind of the next thing that needs to happen is we need real world evidence. We need to follow up people, patients who are undergoing those treatments, and also those who are not eligible for treatment in registries. In Sweden, of course, you have large registries that have been around for decades, I believe. But in many other countries, we don't have any registries at all. There's AlzNet in the US, which is probably a very strong, very good effort. And we're also trying to build an international registry called INRED in an effort to harmonize different registries. But I think that's the next important step that needs to happen. Should we maybe wrap up? And I think we touched on many important topics. Thank you very much for your attention. This discussion is part of a larger program which will cover all the major Alzheimer's disease conferences this year. And I would like to encourage you to provide feedback and use the evaluation form. And this is also a CME accredited activity. Thank you very much. Bye-bye.
Thank you.